It is my pleasure today. I'm Debbie Blessing from ATSU AHEC, and it is my pleasure today to introduce a friend and colleague, Dr. Marla Berg-Weger. First of all, I want to thank you, Dr. Berg-Weger, for agreeing on such a short notice when Dr. Misra's travel agenda changed, as many travel agendas these days are changing. So I appreciate it. I know that you're going to give great information for the students to take back and put into practice. Dr. Berg-Weger's lecture today is Caregiver Well-Being, What is Our Role as Professionals? Dr. Berg-Weger is a professor at St. Louis University School of Social Work and the executive director of the St. Louis University School of Medicine Geriatric Education Center. She earned her social work degrees at Kansas State University, the University of Kansas, and Washington University. Her primary areas of research include family caregiving, cognitive stimulation therapy, driving and mobility, social isolation, and loneliness. So without further ado, we're going to turn it over to you, Dr. Berg-Weger.
Thank you, Debbie, and thanks everyone for thinking that this topic is an important one to be talking about. I greatly appreciate that. I've been involved in working with, studying, thinking about caregiving for many, many years. So it's been kind of an interesting journey, and I'll talk a little bit about sort of where, how has the pandemic impacted caregiving. Disclosures, the work that we do through the Geriatric Education Center is federally funded by the Health Resources and Services Administration. I also have a couple of other funders. What I hope we can accomplish in the next few minutes is for you to gain some insight into the issues about caregiving. Who are they? What do they do? Who do they take care of? And then how are they doing? The needs, and how might we assess that and intervene with that? And then I think in many ways, most importantly, what can we do to support this population? So I want to just start out and give you a sense of what do we know about caregiving. Caregiving was started to be studied in the early 70s. So there's, half a century now of information. Some has changed a lot, some not so much. And I'll try to kind of point that out. So if you look at the whole US, the issues around caregiving really have become a public health issue. And that was really, ramped up when the baby boomers first ones hit 65. And as they've continued to age, we now have, I think the last statistic I saw was we have a boomer turning 70 every 7 seconds. And that will continue for some number of years. So looking at it overall, as a nation, about a quarter of households have someone who self-identifies as an informal caregiver. 16.7% of those expect that they will be providing care within the next 2 years. That could be for a spouse, parent-in-law, or other family member. About half think that they will still be providing care within the next 5 years. So people are finally, I think, beginning to understand this is a long-term kind of experience for people. And 20% of this population reports that their own health is fair or poor. One of the major changes that's happened in recent years is that care recipients, particularly those with dementia, are more likely to die at home, whereas previously, there's still, this happens with considerable frequency, but the trend almost exclusively was that people with dementia were placed in facilities. And because of support systems in the community and family commitments, people are staying at home, which it has significant implications, as we'll talk about, for caregiving. I mentioned that we first started seeing publications and research about caregiving in the 70s. The focus was almost entirely on caregiver burden. There wasn't much around to help. There were few interventions, few resources. So kind of walking through the timeline, the 1990s to 2000s, the focus is still on caregiver burden. However, we're starting to recognize that interventions are needed. They really at that point were focused a lot on the psychoeducational kind of support group model. But we also began to recognize, because the economists started studying it, what is the impact of caregiving on not only the caregiver, but on the work industry, the individual themselves, the overall family. It has this incredible ripple effect. Where are we now? Guess what? The focus is still on caregiver burden, which I think speaks to the fact that we haven't figured out how to lessen that significantly. So I'm glad that it's still being studied. But we do have more services, we do have more resources, and we've recognized probably the most important thing, and you'll hear me talk about this in a bit again, one size for interventions does not fit all. But we also have begun to recognize that we as professionals and providers do have an obligation to this population, whether they're our patients or not. They are part of the patient care team. All right, let's look for just a quick minute here about who are the recipients. Average age may be younger than you expected to see. The majority, not surprisingly, are female. About a quarter live alone, and that does include people with cognitive impairment who are still living alone. Most older adults, in fact, do in the community. About half, a little less than half, own their own homes, but that number is actually decreasing. 40%, give or take, live with a caregiver. That has increased. And that part of that is because spouses are living longer, and spouses really are the largest group of primary caregivers. The number of people living, as I mentioned, in skilled care and in assisted living and retirement communities, skilled care is decreasing. Assisted living and retirement communities are starting to increase. The older you are and the higher your care needs are, the more likely that you are to live with others. And some of that too, we always have to recognize the cultural issues around, how do people view caring for older adults? Because that does really, as you can see here, does vary by culture. Caregivers, again, probably not surprising, mostly female, although when I first got involved many years ago in the caregiving area, that the number of females was probably more like 85-90%. So we are seeing some shifts there, again, because people are living longer, and males are starting to take on more caregiving roles than they have in the past. Most caregivers will self-identify as either the primary or sole caregiver. Overwhelmingly, majority are related to the person that they're caring for. But again, starting to see some minor shifts in that area. Most live fairly close by, within an hour, 80%. Most of the caregivers are married or partnered. And you can see the age range is kind of across the board, from sort of young, I think of 45 as the young middle age. And, you can see that about 45% are less than 45, about a third are 45 to 64, and then 21 are 65 and older. Education, employment, socioeconomic class is, pretty much a microcosm of what our society looks like. This last one, please note this one: a third of caregivers provide 21 to 40 or more than 40 hours of care a week. That when you get to over 40 hours a week, that is high needs caregiving. It's important, I think, for us to think about this issue, because for those of you that are at the beginning of your career, this will have a significant impact. So you can see in 1990, which was not that long ago, we had 11 caregivers available for every older adult recipient. You can see where that goes. It's down to 7 to 1 by 2010. By 2030, which is around the corner here, it's 4 to 1. And by mid-century, we will have fewer than 3 caregivers available. And when this pool of people it's the obvious, the traditional close family member, the spouse, the the children-in-law, that kind of thing. And by 2026, the oldest boomers will turn 80. And you can see that they're going to, that's going to have significant impact because obviously as we age, our caregiving needs go up. Not surprising to any of you, I'm sure, the trends that I just talked about are really due as a result of decreased birth rates. People have smaller families. People aren't necessarily staying as close to their families of origin as they did. And then certainly with women over the last decades working more outside the home, that makes fewer people available. I'm sure that if I were to quiz you all, you would be able to recreate this list pretty closely. But the tasks related to caregiving are usually more complicated, is probably a good word, than many people think. There's certainly the physical aspect, that is helping with activities of daily living and the independent activities of daily living. And certainly, medication management, navigating health systems, those kinds of things. And I think the part that gets lost, particularly by clinicians, is the emotional side of caregiving. I think that, we have to be cognizant of the fact that none of us prepare for being a caregiver. And there's a lot of emotional attachment. I always share this story. My first real rude awakening about caregiving was when I worked in a family medicine center, and we had an older patient who was no longer able to care for herself safely anyway. And I located the daughter, and she came to the center. We spoke, and she said, "No, I won't do it. She was abusive to me as a child. I don't want this responsibility." That was a big eye opener for me. And so I think we do have to take all of those kinds of things into consideration. That's certainly the exception. Most families do step up, of course they do. But you're also dealing with family members who have not maybe accepted the diagnosis, particularly if it's related to cognitive impairment. They may still be in denial. They may be grieving. They may not be prepared to see themselves as a caregiver and feel inadequate around that. Or maybe they just simply don't have the bandwidth. So they're juggling lots of things. So I think we just can't sort of forget about the complexity of the caregiving relationship. First independent study that I ever did was to look at why caregivers provide care. And here's what I found. And good news, bad news, I'm not sure how to frame that. It hasn't really changed. More recent work that's been done has really confirmed what I found all these many years ago. So it broke down into 4 categories. When you ask people, why are you a caregiver? It was because there was no other perceived alternative. A request, and these often came in the form of deathbed requests, where a parent was dying and said, "Please promise me you will take care of your mother or your father." Sense of familial duty or obligation, and that has to do with family rules and family culture. Some families have just sort of pre-designated rules about who's going to be the caregiver. In some cases, it's a youngest daughter, or it's the person who stays closest by, or it could be the son. It just really is very individualized by family and to some extent culture as well. And then this last category was a little harder to really kind of identify, but it's the group of people who just see themselves as natural caregivers. They're always taking care of somebody. So in the interest of time, I won't ask you to put the answer to this in the chat box, but of all of these groups, I always like to have people think about which group do you think is the most stressed? So again, in the interest of time, I'll give you the answer. It's the ones that there's no other alternative. So these are the people, if you think about it, who didn't necessarily sign up for this. They didn't volunteer. They may feel like they got stuck with the role. And so, of course, it's not surprising that they would be more stressed. And you can see here at the bottom, some more recent research shows that many people do, when asked, tell you that they provide out of a sense of obligation, with over half saying there was no other choice. So I think, again, we have to take all of those things into consideration when you're looking at that caregiver sitting in front of you. So let's shift a little bit here and talk about how caregivers are doing. Caregiving is being seen much more so as a career because it's so long lasting. People care for over, up to 20 years and sometimes even longer. So I think we have to help people know that this could be of considerable duration, and that they need to be able to maintain their well-being throughout. Sadly, but probably not a surprise, the negative reports, even with the resources and services that are out in the community and the increased awareness, the negative reports still outweigh the positives. 80% report that they are stressed. Over a third of those report high levels of stress. And I won't read all of these bullet points. You can scan them quickly. But I think the takeaway from this slide is that caregiving, particularly the more intense caregiving, really can impact every aspect of the caregiver's life. And think about those people who didn't come into this role voluntarily. They maybe don't have the time, the energy, the skills, or the support to do this. And it's, of course, going to have this kind of negative impact. And the risk factors, again, are very consistent with what I just talked about, in the sense that, those that are most risk for having a negative experience are those who have no choice in the role, those who care for someone with dementia, and those that have been in the role longer. And race also has some impact. Some of that, again, don't forget about the cultural impact of that. So continuing on, what caregivers also will tell you, if you ask many of them, that they really are experiencing this kind of loss of self. And by that means, maybe if they're watching their spouse have progressive dementia, they're losing their sense as a spouse because they're losing their spouse, but yet they're still there, alive. And they also can just get caught up. You think about young parents who talk about, I was this person and now I'm somebody's mother, and we all get very, at that point in life, caught up in the role. Well, that happens in caregiving as well. Unfortunately, and part of this is due again to the point I made earlier about lack of preparation and anticipation of being caregivers. Most haven't really ever planned for that and don't have a plan for how they're going to do this, in part because they don't know what the future holds. But in some cases where you maybe do have a sense, particularly if the person has a progressive dementia, there has to be some planning, and people just aren't aware that they should be thinking about that. I was surprised about this next one in the beginning, but as I've worked in this area for all these years, I'm not surprised any longer, but service utilization by caregivers is low. There's a sense from many, many caregivers that I need to do this on my own. To ask for help is not acceptable. So I think that we have to keep that in mind as well, and meet your caregivers where they are. One of the things that's happening, because people are staying at home and in the community, the caregivers are providing higher and higher levels of medical care for which they don't have training. So if you are working with an individual or family where there are pretty high medical care needs, just check in with the caregiver and find out if they're comfortable, if they know what they're doing, and then try to connect them to a place where they can get the training they need. I keep moving forward here. So what does impact how the caregivers are going to respond to caregiving? All on this list are relevant, but I bolded clearly the top three. Those who come to the role abruptly, like today I'm not a caregiver, my spouse, my parent has a stroke, has a catastrophic health event, and now I'm a caregiver. Those tend to have more negative or more impactful kind of responses to caregiving versus the person who kind of just gradually eases into it over time as the person's needs increase. Duration, the longer you go on, can certainly impact the response and not in a positive way. And those that are not spouses, but who are providing care are more stressed. I think in the case of spouses, there's some expectation, although not always an acknowledged one. There's some expectation that, yes, that's part of this contract, if you will, of marriage or partnering, that I will take care of this person in sickness and in health. So I think particularly, watch for the adult children, even grandchildren, caregivers, because they may be struggling. I do want to point out that there are many, as you can see on this slide, positive impacts of caregiving. And about half of people really do say that some positive things have come from caregiving. And again, you can read the list here. People say, I never thought I could do this. I found strength and patience and skills and knowledge and assertiveness that I never knew I had. Some people will talk about it was a way to heal those estrangements or maybe the broken relationships. There's a sense of giving back, particularly for adult children and grandchildren, that this person took care of us and now it's our turn, and people just really being able to connect in ways that maybe they hadn't previously. Especially, I've heard a lot of stories over the years about, we had mom come live with us, and my children got to know their grandmother in a way that they never would have otherwise. So do know that there are positives, and ask people about those too. I want to take just a minute here and talk about kind of what has the pandemic, particularly around loneliness, social isolation, what kind of impact has it had on caregivers? And the short version of this is not a good one. Caregiver loneliness has increased, mostly because in these cases, the caregivers are older adults themselves. So they've been social distancing, they have been staying in, they have been much more protective of themselves and the care recipient. So loneliness and social isolation have both increased. And the downside that happens as a result of that is that they have not done the usual non-caregiving activities because it's not safe, they're harder to schedule. And the prioritizing the non-caregiver activities is that precedes the pandemic, certainly. So that was an issue before, because you get consumed in the role, particularly if it's a higher one, higher care needs. And social isolation is linked to dementia, and obviously much more so. And again, that predates, but it's all just been exacerbated by the current state of the pandemic. And I think the increased, as the last one talks about here, and this study, by the way, I just read this like 2 days ago. So this is hot off of the press research. The increased mental health and stress challenges have really decreased the caregiver's ability to see the positive effects. And then, of course, depression. Depression has been a struggle with caregivers before for all the reasons we've talked about. But mostly now it's related to sort of this being so isolated from others. And just when we think it's safe to go back, we're obviously in the middle of a surge again. So again, keep these things in mind. Assessment, critical. And I'm going to let Debbie talk at the end here and tell you about some projects that she's been spearheading here in Missouri. But just quickly, it's essential that you do assess how the caregiver is doing. And however you do that, I'm going to share a tool with you here, but I'm going to just encourage you, if you don't do anything else, just ask. ask how they're doing. And there's some wonderful tools out there. We have a rapid tool that is evidence-based that we think is a good one to work into a clinical interaction with a caregiver. And obviously the caregiver might be your patient, but the caregiver may also just be there with your patient. So you have to think about how to structure an assessment if the caregiver is accompanying your patient. Be flexible, but again, the takeaway here is just ask. One thing that I cannot emphasize, and I mentioned earlier that I'd come back to this, one size does not fit all. If you've got a 25-year-old granddaughter taking care of a grandmother, that's a very different kind of caregiver relationship and situation than an 80-year-old spouse who's been married for 50 or 60 years, the person that they're caring for. And then you've got everybody in between, the caregivers with young children and caregivers who are maybe at the empty nest phase of life. So it's important that you not just sort of see them as similar. Just because you've met one caregiver means you've met just one caregiver. So take that into consideration too. The tool that I mentioned is the Rapid Caregiver Wellbeing Scale. This is a much shortened version of a scale that my colleague Sue Tebb created many years ago when she worked in the VA system. And we validated it, we shortened it and validated that version, and several years ago created the rapid one. You can see here that this is a quick scale. It's divided into basic needs, both in terms of activities and actual needs. It's intended very much to be a conversational tool. So you can use these items as a way to have a conversation with the caregiver and then revisit as time goes on to see if these things are changing. It's a great springboard then to talk about utilizing resources, importance of self-care. One of the things that caregivers don't often think about is if they don't take care of themselves, which they often will neglect, what happens is that their health declines and they're not, particularly the older caregivers, and then they're not able to provide care. And most people don't want that to happen. So how are we doing? Well, I'm sorry to say, we're not necessarily, and by we, I mean professionals, we aren't necessarily doing a great job. We're getting better, but in some areas. So what do caregivers want? Well, the majority of caregivers, when surveyed, and this data comes from the Alzheimer's Association, they want more information on how to keep their loved ones safe, and they particularly want to know how to handle the stress and the burden aspects of the caregiver experience, and also to navigate the service system, which obviously don't need to tell this group, just has gotten more and more and more complicated over time. These last two, though, I really don't want to be too doom and gloom about this, but they are what they are. Less than 30% when surveyed, and this is data from 2020, less than 30% said the healthcare provider had ever asked them how they were doing or if they needed help. And if you notice the asterisk there, go down to the bottom, 55% of those people who were caring for someone with dementia were never told of the diagnosis. So again, transparency and inclusivity are the keys here to making sure that you are in touch with how the caregivers are doing, which ultimately impacts the care that they're able to provide to their family member or whoever they're taking care of. And only 13% had been asked what they needed for themselves. And that number has actually been on the decline. So I don't know that I have a good explanation for that. But I hope that the next time I pull up their facts sheet for this last year, that number is going back up. Think about, as you're interacting with caregivers and the patient, think about where are you meeting them? At what point Is this somebody who's been your patient for a long time, and the diagnosis, particularly around cognitive impairment in particular, is something that happens, in an established relationship that you have? Are you seeing them at diagnosis? Are you seeing them at the time of placement or at hospitalization, or at the end? Because the way that you interact, the support that you can offer will differ. Just as one size doesn't fit all caregivers, one size of intervention doesn't fit for every phase of the caregiving process. And again, think about some of these go on for 20 plus years. So if, particularly with long-term patients, you have an opportunity to be involved over many years. I'm going to talk real quickly here and allow plenty of time for questions. And I hope that some maybe are going in the chat box. Debbie's monitoring that. So thinking about caregiver interventions, this list that you see before you here are sort of the traditional kinds of interventions, which many are evidence-based, been around for decades, and are proven to work. But again, remember, not every intervention works for every caregiving situation. Some of it has to do with access, some has to do with caregivers not feeling comfortable, kind of farming out care, if you will, to someone else. And particularly this second one, where there are a number of respite and adult day service programs available, not in every community, but in many communities. There's some kind of support in those areas, or there's at least financial opportunities available to support getting that kind of care. But that requires, for people to feel comfortable to use those kind of services, they have to be willing to say, yes, this is okay. I'm not being negligent in my care and my love for this person if they go to an adult day service, or we occasionally use respite care. Oftentimes, go back up to the first one on the list, the individual and family counseling can be immensely helpful. But again, I think in many cases, the first barrier that you have to overcome is the person or family comfortable? And we do have some resources I'll talk about at the end that people are the services are there. It can be very helpful, but you've got to get people over that feeling of, oh, I shouldn't need this if I was doing a good job. Psychoeducational groups, support groups are probably the primary intervention, and particularly ones that people will feel the most comfortable. Support groups, well, in person right now is sort of a moot point, but support groups generally, even before the pandemic, attendance was going down. And in part, that's really due to so many things being available online. And I know support groups now, through our St. Louis University Aging and Memory Clinic, we pivoted to virtual caregiver support groups early in the pandemic, and have been very successfully doing that since then. But you can see here, most people find peer support being very helpful. And it's not considered therapy. And I think for some people, that's an important piece. What can we do? Well, we need to, I'm going to start over on this right-hand side under the regularly asked. How is the caregiver doing? Please, please, please make that a part. If you ask somebody if they are a caregiver, and if that's a patient, and ask how they're doing. Ask what they do. What do they need? Do they need help? How have they tried to get help? And then last, but absolutely not least, what are they doing for themselves? That's what I hope you will absolutely take away from this presentation, is just ask, and then, but that does require you to have something to offer, depending on how the person asks. In terms of training for caregivers, there are a number of evidence-based programs out there, and ways to engage people, to prepare people to do some of that more high level care, and making sure that discharge plans, treatment plans all include the caregiver. Lots and lots of resources are available online. There's all kinds of apps now available for caregivers. And we've gotten much smarter in terms of making sure that both the assessment tools and the interventions are more culturally inclusive than they have been in previous years. Technology is great. Online resources are wonderful, but we have to recognize that many people still don't have access and may not ever have access. So again, just handing out the sheet with oh, here's a link to, to an online program that you can get information. It if you haven't done your homework to find out, do they have access? Is this something they feel comfortable doing? May not be the most effective thing that you can do. One of the things that all of us, and you in particular as physicians, I think can do is let caregivers know that it's okay to ask for help and that it's okay to ask family members for help, because oftentimes that's a big stumble for things. It's okay for them to do what they perceive may be selfish by taking care of themselves, because you want to remind them that they need to, if they're going to be a good caregiver, they've got to be healthy themselves, and to help them think through plans. Now, I realize that, you don't have unlimited time. So start the conversations and then get people connected, get your patients and family members connected to others who can continue that conversation. Acknowledging that pretty much there's a big range of feelings that fall within the normal range about this, and that it's certainly very normal for people to feel stressed, and that they do need to find some kind of balance. Encourage them to do things just for themselves, but to know the warning signs, and that's one of the things I think that so many agencies training now includes, is know the warning signs of your own stress. Ideally, in the ideal world, all these interventions that I've been talking about include all of these things that are listed here: education and self-care and mindfulness, yoga, breathing. All of those things have been found to be very effective for caregivers. But again, people to that point where they have access to them and are willing and able. One of the things, particularly around dementia caregiving, that is so often overlooked is the anticipatory grieving that goes on because they're losing that person and they're grieving. And we actually did a study, Suteb, who I mentioned earlier, we did a study some years ago of post-caregiving experiences. And people in that study, we did a qualitative component to it. And people talked about how guilty they felt because they weren't grieving enough now that the person had died. And when you kind of drill down into that, they did a lot of grieving before, and they may not even realize that's what they were doing. But again, this is where support groups can be really helpful. Take note of this statement at the bottom. Nursing home placement can be delayed by as much as a year and a half when caregivers receive support compared to those who don't. So support can be highly impactful. The chart that I like, and I don't know that people necessarily could use this, but it'd make for a great handout to be able to hand to the caregivers. And it's sort of a contract with themselves. What are they going to do? How's it going to be done? When? And how are they going to be accountable for it? And what's in that left-hand column under what, that can change. These are just guidelines of the kind of things that we know will help caregivers, some caregivers at some points. And then I think making sure that they do know that self-care is not just okay, but it's essential for them. And I think that you can impart some of these kind of things to them, that it's, as I've talked about, it's okay to ask for help, okay to take care of yourself. It's okay to play hooky, but to know themselves. And I think, again, support groups can be very helpful for that. All right, I want to talk about some resources here, both regionally as well as statewide. And Debbie, thank you for providing these first two. There's the Family Caregiver Resources for Missouri, and this is it's an AARP, American Association of Retired Persons, if you didn't know what AARP was, where you can go to their website and click on Missouri and Caregiver Resources, and you'll find all kinds of things that are available across the whole state. And we have an Alzheimer's Association that covers the entire state, and they have just an amazing number of resources. The Missouri Rural Health Association is a good one for information on the caregiver training program. And then I mentioned just a minute ago the St. Louis University Aging and Memory Clinic. We offer several things for caregivers. As I mentioned earlier, the caregiver support groups. We have 3 or 4 now that meet weekly, all via Zoom. And then monthly, we have a caregiver lecture series. And we do archive the caregiver lecture series, much like this one is being archived today. And those anyone can listen to those by going to our website. The Alzheimer's Association, I already mentioned them. And then Memory Care Home Solutions is an organization that is located physically in St. Louis. But just as the rest of us have, they now provide almost all of their services virtually. So they've been able to expand their reach, certainly beyond Missouri. And they offer not only training, and in fact, we are co-sponsoring with them a dementia webinar on April 8th, and I can provide that information for Debbie and to share with you all. But they provide primarily social work and OT services. So they're a wonderful organization. We partnered with them on many things over the years. Just if you know of other resources in the areas where you're located right now or anywhere in the state of Missouri, please put those in the chat box and I will add them to my list. Lots and lots of other resources. As I said, we've studied this issue for 50 years. There's so much out there. Local area agencies on aging. Every county is covered by an area agency on aging. AARP, they have more resources than you can even begin to imagine. Alzheimer's associations cover the entire country. Great resources that are available. And share these slides if there's interest, and you can have access to all of these. All right, so take-home messages before I turn it over to Debbie. Don't forget about the caregivers. It's probably I could have just put that one on the list and moved on. But do assume that they can benefit from your support as well. It maybe doesn't come under the job of the physician or the nurse practitioner or the PA necessarily, but you're a key figure in the life of the person who is being cared for, whether they're your patient or not. Do see the caregiver as a member of the patient care team. And I hope I've made the point that to regularly ask the questions and engage the caregivers about what they're doing and what they need and how they're doing. Know something about resources, or at least know who knows about resources. If you're not in a permanent situation now and you don't know that community, somebody does. So make sure that you know who that someone is. And certainly, think about incorporating on a regular basis into your encounters some kind of caregiver assessment. Okay, so there's my information. I want to going to stop sharing, and I'm going to turn it over to Debbie, who's going to tell you about the work that she and the AHEC have been doing.
Thanks, Dr. Berg-Weger. Yeah, so just to briefly mention, so we have over the last 2 years been working with like Southeast Missouri, AHEC, Mid-Mo, currently working with Phelps for the last 2 years. actually integrating a caregiver program, and Phelps Health, it really has taken off. They use the rapid caregiver well-being scale in a variety of different care settings at the hospital and around the community. And then we just started working with Northwest Missouri AHEC, so up in the St. Joe area at Mosaic. And they're also integrating a very similar program using the rapid caregiver well-being scale. We have tons of those assessments. I just had 500 of them printed. So if you're at a healthcare facility and you go back and you're like, because this is what happened, I'll just share what happened at Phelps. Dr. Berg-Weger did a similar training with them. And when the clinicians left and they had a huddle, they sat down and they were like, this is something we thought we were doing, but after hearing this, we recognize we're not doing as much as we thought. And so they developed a whole plan, do, study, act. And ultimately through all this, they created an entire position at Phelps Health to look at caregiving. So would love to be able to share some of these rapid caregiver well-being scales. If you are at a facility that would be interested, we'd be happy to talk further with you about it. We have all kinds of resources available to us through the Geriatric Workforce Enhancement Grant. So just wanted to kind of give a plug to that. And if there's interest, you can contact me or send a note to Marcy and she can connect you with me. I can put my email in the chat box. So anyway, we're just really excited about trying to expand this program throughout the state of Missouri. So it may be coming to a center near you. So I don't see any questions. Do we have any questions from the students? Or any in the chat box? Or you guys, yeah, just any questions from anyone, yeah.
Yeah, I have a request for the slides. This was a great presentation, and Debbie, I love that you're working with the AHECs and delivering that. Actually, I'm having some friends that are starting to transition into somewhat of a caregiver role. So this is very timely for me for sure. And just knowing that there are resources out there for someone who is having to transition a parent, and how do they navigate the services? Because for my friend has been very challenging in who to call and how to reach out, how to work with the case manager, working with the nursing home and the pharmacy, and just navigating all of that. And, the stress of the parent then transferring to the child, it just is, can be very stressful. So
for sure.
Great presentation. Thank you guys so much.
Yeah.
Well, I think that, transitioning into a caregiver role is, if people have the opportunity to actually transition, that suggests over some period of time.
Yeah.
That's a great opportunity to be able to provide education for them on what is available and to kind of help to normalize what's coming. Although you can't predict, definitively what's going to happen in their particular case, but you can kind of say, if your family member has, a progressive dementia, for instance, here are the kind of things to be thinking about. And that's where organizations like the Alzheimer's Association and Memory Care Home Solutions can be so helpful. They can do care planning with people and help them to anticipate. The group that I think is that we need to be particularly concerned about, though, are the ones who it's that abrupt onset of the role that people just, most of us don't even want to think about, oh, I might have to take care of this person. I think about it a lot, but obviously I'm the anomaly here because I've thought about this whole issue for many years. And I think, though, that the typical person doesn't have a reason to think about it. And especially if you didn't grow up with caregiving happening in your family, you don't have good role models for that.
Right. And I wonder, oh, go ahead.
Sorry, Debbie. No, go ahead. You're fine.
I was just going to say, our focus is geriatrics, but just from a personal perspective, some that know me, my son was in a terrible accident. So I went to bed one night and 6 hours later was caring for an adult son who had a traumatic brain injury that required tons of care. And so, in the matter of, so when we're talking that abrupt, in a matter of hours, you become this caregiver and you're thrust into the, and I've been around medicine my whole life, but when you're thrust into that, from a person who's been a caregiver for someone who had cancer, who was older, and then to be, one who's just like thrown into it. I had experiences with, clinicians that didn't think about me being my son's voice. And so, this is a really personal topic for me, but, I just encourage, everyone here, to think about that when you encounter a family member, to think about them and engage them. I was my son's voice, and I had a team of neurosurgeons who came in and huddled like we really weren't there. And so, I had to let them know I am his voice. I am the only person making decisions for him. So I think it's really important to think about, it's not just older adults, you see it for kids, for young adults. And so, to think about that whole age spectrum. So.
Well, Debbie and I have a shared experience because I too had an adult child who went out on a second date with somebody and ended up in a coma because of a pre-existing undiagnosed heart condition that no one knew about. And so I too was in the ICU when 14 people rounded, and having thought about these caregiving issues and been a social worker for decades, I just sort of bullied my way into the conversation. I was not going to be forgotten. And actually, after 6 weeks in the hospital and a miraculous recovery, one of the residents said to me on one of my daughter's last days in the inpatient rehab unit, he said, "We just want you to know we think you've been a great advocate." And I said, "Well, thank you." I said, I'm guessing that may be your very kind way of saying I was a pain in the what. He goes, "Oh, no. We really appreciated, what a great advocate you were." So I took it as a compliment. Yeah. But I think that all the things I talked about here today, I think do have applicability across the age spectrum, when you're.
Oh, absolutely. Yeah. Any questions or comments or anything before we let Dr. Berg-Weger go? I know it's a Friday at noon or 1.
Well, I will put my email in the chat box as well. I know it was on the slides, but here it is as well. And if there's anything I talked about that you want to know more about or any of those resources, I will send the slides to Debbie. And thank you all. And we're just so pleased that ATSU and AHEC are doing these projects, because it's an important issue. So we thank you for that.
Thanks, Dr. Berg-Weger.
Okay.
Thank you so much.
Bye, everyone.
Thank you so much.